Right, hello everyone, thank you for joining today. So my name's Kate Hayes. I work for Bladder and Bowel Care Services in Mid and North Devon. So I may have met a few of you already in our everyday work environment. So we'll just move on. So as long as we've got all microphones off for the time being, I'll start my presentation. So if you do want to ask any questions, like Anne said, if you want to chat as we go along, you just put your messages and we'll look at them at the end and go through them and see if we've got similar questions that we want to be asking. So starting off with the continence care. Okay, so again, there is a few of us that do the continence care, and we all are in close contact with Leslie Turner, who is the Essity clinical consultant, and so Essity is Tenor as we all know it. Okay, so moving on. Move on. Oh no, come on everyone, let's move on. Sorry. Okay, can you see the aims and objectives? We moved.
No. Not
There
yet.
we go.
Yes, there it's coming. Just
Well, thank you. It just needed warming up. Yeah, okay. So the aims and objectives of this presentation is to identify the many different factors to keep us continent and different types of incontinence. So we've also got a session on how to complete the 3-day diaries accurately, understand why we want this information, and to increase your knowledge of a basic part of care and incontinence products and know how to fit them and to fit them correctly for the residents or clients. Sorry. We've got a bit of a delay on this for some reason.
Sorry, mine's not working at all.
I don't know what's going on.
Kate foolproofed everything she could ahead of time. It's there now, Kate. It's there.
We're there.
Just takes
Sorry,
a minute.
everyone. I'll do my best. So, reasons for incontinence. Sorry, it's not come up with all my writing, has it? And it's too small for me to read. Sorry. Sorry, everyone. Right, so we'll just move on. So before the assessment, what we're looking at, we want to see the treatments for the incontinence, because these can vary according to what's causing it. For example, it could be a urinary tract infection. So I'll say resident in all cases, but if it's just your clients, understand this is this presentation of today. Your resident may need antibiotics and this encouragement to drink. But to reduce irritant fluids like caffeine and citrus and carbonated drinks is important. And I think, as you all are aware, I think for a urinary tract infection, just drinking plenty of plain water is as good as anything. As when we've met up with different doctors and people, that's what they do recommend. So just simple water. Constipation, we want to promote healthy bowel habits and to prevent or relieve constipation. And there is that Q fit test for bowel cancer screening. Okay. Moving on. We'll just keep smiling. Here we go. Come on. It's going to jump. Oh, sorry about this today, everyone. There we go. So we've got different types of urinary incontinence. So we've got stress, urge, overflow, and I always put cognitive on that as well, which is another little box for us. And that's what we usually ask for when looking into continence assessments for everyone. This is so on a go slow. Sorry, we've only got an hour, haven't we? There we go. So stress incontinence. So this is symptoms when leaking small amounts of urine when coughing, sneezing or laughing, and that leaking without the sensation of needing to go. So the causes of stress incontinence can be a weakened pelvic floor, an overfull bladder, and a treatment can be exercises to strengthen the pelvic floor muscle. And this is a muscle that can be improved if you've got the right person that can do the exercises. Like if you've got somebody with dementia, then were a little bit more different, but this is to try and get people to help themselves a bit and not just to be reliant on TENA products or containment products. There is a little app you can get, because everything's technology, called the Squeeze It app, which I think it does cost you about $2.99, but for that it prompts you to do pelvic floor exercises. And so if you do tend to forget, it's just a little idea that can just stick in your mind, that you think, oh well, I think we all could probably in later life do with keeping this muscle active and working. Again. Sorry, it's on a go slow. Sorry guys, there we go. So symptoms. So this is for overflow incontinence. So the symptoms can be a poor flow, dribbling incontinence. Can I hear some music on somebody's?
Simply having a wonderful
That's-
Christmas. Who's got that going?
That was going on.
It's me. I'm sorry. I didn't realise I wasn't muted. It's Tracy enjoying her Christmas music.
All right, I could hear a little bit. That's no problem. No problem. So obstructive overflow incontinence. So we've got poor flow. So we've got a dribbling incontinence, being unable to go frequently, and urgency. So lots of urine being left in the bladder even after going to the toilet, and this can cause a residual, which may result in this resident needing a bladder scan. The community nurses may be able to help you with this, or you'll need to contact, like you say, your GPs or the bladder and bowel service. So the causes of overflow incontinence can be narrowing of the urethra, bladder muscles not working properly, and an enlarged prostate in the gentleman. So the treatment for this would be medication to improve the flow and intermittent catheterization to drain the bladder. Doing better, everyone. Urge incontinence. So symptoms, it's frequent urination. So large leakage of urine, the urge and need to go and not get into the toilet on time. So that can result in having to change clothes and again needing TENA products and prescriptions for these residents. Causes: an unstable or overactive bladder. There is no known cause, but caffeine, alcoholic, carbonated, citrus drinks make this worse. So the treatments will be to look at the fluid intake, reduce drinks that irritate the bladder, and bladder retraining. So all these little things which we're all doing. There we go. So I usually say, can you name some types of drinks that residents and people, are drinking in their own homes? Again, we want to, if they are suffering with incontinence, if they will, like I say, it's their choices, but to drink decaffeinated products, so decaffeinated teas and coffees. But if you do this too quickly, I think you would give them like headaches. So it needs to be introduced gently, and then you will hopefully see a difference in them, rushing to the bathroom. So blackcurrant, that's anything else like that will irritate the bladder. Hot chocolate is another one that can irritate. So if somebody's going to bed off a hot chocolate, it can often mean that they're getting up in the night as well. See what we've got. Right, so we've got fluids there. Come on. So the fluids. Oh, I do apologise. Here we go. So again, really just reiterating what I've said. So things that don't irritate the bladder. So we've got the water, decaf teas and coffees, diluted squash, milk, Milk's good and kind on the bladder. Milkshakes, smoothies, and herbal teas. So then on the other spectrum, we've got things that will irritate. So if somebody, when you're talking to them, is drinking teas and coffees regular all day long, fizzy drinks, alcoholic drinks, hot chocolate, green teas, another one, caffeinated fizzy drinks, and fresh acidic drinks like pure orange and apple juice. So those are all things that you might not always realise if somebody's drinking regular can upset the bladder. Come on, there we go. I think it's wanting us to keep on this slide. Come on. Right, so this is a good one that we need to watch. So how much do you think we need to drink every day? So we need to drink 1.5 to 2 litres a day to remain healthy and, you know, be cognitively awake and happy, and then just for your body to work well. So drinking lots of bladder irritants will give the feeling of needing to use the toilet more frequently and urgently. So try to avoid these types of drink, and this can significantly improve a person's continence, because we're not wanting people to have pads if they don't need them. We want them to carry on using the toilet, because that's what we're all wanting to be doing, like we've always done. Try and move this on. There we go. So we've just got a little diagram of other things of what to eat and drink for a healthy bladder and bowel.
Kate, while the
Yeah.
next one's just coming up, I know we said we would do questions at the end,
Yeah.
but I thought while we were waiting,
Sorry, it's been a
Fran's,
bit difficult.
no, that's not your fault. Franz said that she heard that rather than decaffeinated drinks, barley squash was a kind of optimal one for supporting continence. Is that one that you particularly recommend? She was going to ask you, but she can't stay till the end.
All right. Yes. I think that's kind. And yeah, you don't often see a lot of barley.
Yeah, but the elderly often really like it, don't they? Because it
Yes.
reminds them of, yeah. So definitely another thing that you'd recommend is barley
Yes.
squash.
Yes,
Brilliant.
that'd be
Thank
better
you.
than getting your blackcurrant. And if you make it so that it's not just as strong, because some people, they like drinks in a certain way, don't they? So don't just make it really strong. Make it a little bit, you know, more diluted, and if they'll be happy to drink it like that, obviously. But yes, not too strong. So well done. Okay. So I'll just move on to the bowels. So bowels haven't to be forgotten in doing continence. So by being constipated, this can lead to urinary incontinence. So dehydration and reduced tissue viability. So we highly encourage, as you know, in your jobs, that's what you'll be doing all the time, to promote voiding for bladder and for bowels. And we do kind of encourage that if a patient has regular bowel movement at a regular time each day, then to get them ready beforehand and get them to the toilet so that they can open the bowels like in peace. Because I think it is one of the things that if they, you know, have a set routine, that people do like to go, say, first thing in the morning before the day begins. And so if that's what they're used to, try and encourage this, and it's less stressful for them, and then hopefully they won't be needing anything to make them go to the toilet later on. So likewise, people having these regular routines throughout the day, this promotes independence and can solve significantly and improve both urinary and fecal incontinence. So yeah, put the emphasis back on the person. I'm sure they'll appreciate that. Moving on. Let's try again. We're struggling on with these, but we're doing it. So what causes constipation? So we've got immobility, neurological problems, fluid balance, diet, muscle weakness, medication, and again, poor access to the toilet. So again, if you're like carers and you're waiting, you know, the residents waiting for you to come to get them to the toilet, then that's when sometimes the accidents are happening, and this, being in control of it is all going out. So they need you to be aware of all this side of things to make it go smoothly for them, and hopefully they'll use the toilet and not need the pads. So we've got what causes fecal incontinence. So we've got impacted bowel, infections, medication, medical illness, and then we've got toilet positioning. And raised toilet seats, like on this diagram, can make all the difference. So if you have got somebody that's struggling with the bowels, if you look at the little box that's in red, if somebody has sits on the toilet and they have raised knees, so if they can put them on a little stool and just lean forward, this is the best position to open your bowels if somebody's struggling. And like I say, be patient and give them time. Okay. So again, we've got constipation signs and symptoms in non-communicative patients. So we've got any behavioural changes, abdominal pain, bloating, loss of appetite, weight loss, a distended abdomen, rectal bleeding and pain when pooing. So monitoring for constipation is the most important thing we can do for those we care for, especially for those who find it hard to communicate or maybe too embarrassed to talk about their bowels. It's not the easiest subject to bring up. So we want to look at the fibre intake in residents' diets, and we must remember to make our patients, residents, feel comfortable and confident in coming to us if they feel they have a problem. So remember that poo does matter. So that's just pictures of what will help. Right. There's only so many buttons I can press, guys. There we go. So incontinence assessments. So I don't know if you all are doing the continence assessments, but I'll just go over it briefly. So from our side of things, we do need the 3-day diaries and a continence assessment completing to get people on the NHS system for Tenor products. So if you feel that your resident needs to be added onto the Tenor system, we need the prescription filling out and 3-day diaries and bowel charts. And on these forms, we want patients' details, the medical history, the medication, and if they are mobile, and the products that they are currently using. So it's important when completing these documents for both the intake and the output that when completing the 3-day diaries that you don't put wet pad on any documents that get sent in to the bladder and bowel service, because it'll only need to be completed again, because we do need this measurement in mils. So if you can try and remember that from today, it's really important, because you do struggle sometimes with this when you go into patients when they're in their own homes and they don't have everything at hand. So hopefully I'll give you a few pointers of how to try and get this information, and then they can get on the NHS pad system. Because we have to remember that even when we're doing this, that the pads are the last resort. Okay. And the key points: weigh and measure everything in mils, please. Okay. And this is the paperwork that we have that I think you'll all be familiar with, because nothing has actually changed. On all the documents, we will need the name and the NHS number, and the date that the assessment was completed, and their date of birth. And then each of these forms starts at 12 o'clock midnight, and we want you to do your best to get these completed for 3 days, 3 consecutive days if possible. But if you miss a day, you can then do one on the following day, so that we've got that information for 3 days. So we have the input, so which we want all the drinks that they have during that day, whether it's water. But again, if they don't finish that drink, just don't put that it was 250. We want to get it as accurate as possible. So if they've only drunk half, just put that they drank half on it, and do that for those 3 days, again starting at midnight. And then we've got the output chart, which again we want, because they usually have been purchasing products themselves, that will need weighing on the weighing scale. So if you can put the wet pad in a little bag and tie that up and weigh it and do that for 3 days. People aren't really always very happy about doing this, and especially if they are in the home. But for our service, this is the information we need in to get the correct product for that individual. So we do need this information, and it is important. So we do ask you to do this and explain to the resident or patient that bladder and bowel do expect this information, and we do need it to work forwards, because what we can see then what pad they would be needing throughout that day. Bowel chart again, you put the date and how many times the person goes, and then we've got the Bristol stool chart underneath, just to give you ideas whether it's a type 1 to 7, 7 being loose stools. Okay, so that's the paperwork. It then goes to a prescription. This is a new one at the moment. I don't know if it would be the senior nurses that complete this. It would be start from the top and running down, saying like if it's North Devon, you just tick North Devon, assessment date. If it's a new patient, give that a little tick, patient's details, and then you start from, oh, sorry, let's go back. You put the title, the surname, NHS number, and fill all these little boxes out. And then you go down, starting at the tenner comfort range, which come with the netty knickers. So anybody that does have a tenner product on the comfort range, always please put the netty knickers with it, because that puts the pad in close proximity to the body, and you get the best out of the pad. You have to require more than 2, but you wouldn't get more than 4 to get on the tenner system. So you won't get 5 products, and if you don't require to have 2, then you wouldn't hit the criteria, and so you wouldn't get on the tenner prescriptions at all. Okay, so if somebody hasn't had products before, we would prefer it if you ordered the tenner comfort and didn't just start off on the more specialized products. Okay, if you can remember as well that the comfort range is the comfort, because we do have an actual product that's called a slip. So if you happen to call the comfort a slip, it gets everybody a little bit confused. So the slip is the one that we have fastening at the sides, like I always kind of say, like the little babies' nappies, and then you understand how that works. But then we also have a tenner flex, which has got a thick waistband which goes around the waist, which we just have in the plus absorbences. Okay, so that's what the NHS offer, and we do, just forgot that, the tenner men down there. The tenner men is just like a little triangle of a product, which is good for a gentleman. It's just got some dribbling and prostate problems, but that little triangle again, it can be used for if somebody's just got smearing but they don't really need a product. You can use that one at for the back and just slip it in, because it's got sticky on the back, and you can just pop it in someone's pants that way. So that's quite above board, you are allowed to do that. And that's the tenner prescription. So if you're not using that one at the moment, then after Christmas, that is a must, that it has to be this one that's being completed, because we've had some changes. Okay, so hopefully you have got that. I've now gone and said what I've already got, so we can prescribe up to 4, minimum of 2. You can move from like the tenor comfort range to say a slip for night time if that's when it's worse at night and a higher absorbency is required. If when you do your assessments, if you don't give us the information on the 3-day diaries, we actually look at them so intensely that we will change the prescription from what you're asking if it does not give us that information. So always be mindful just before you give it to say the nurses or sending them in yourself, just reread it to check that the information you've popped on that bladder diary coincides with the tenor prescription of what you're asking for. Because it does, on the tenor prescription, we do have like the waist sizes and the absorbencies. So if you have all that information, it can run smoothly. But if you've any queries, you can always contact Bladder and Bowel Service and we will help you. So for North, sorry, I seem to be a bit north here. It's the top one, which is iduh.bladderandbowel@nhs.net, and the south email is bladder and bowel south@nhs.net. So if you want to jot those down, depending on your areas, that's where you would contact people, and that's where you would send any queries. So going from that, I have got oh, this is more a bit of what Leslie, who often joins me on, and she would be explaining how the pads work. I might as well just add to that little bit while we're on. So the pads are in layers, and each layer has a special purpose. So the top layer keeps you dry by letting the urine through. So that goes quickly into the base of the pad and it keeps it away from your skin. So you can keep a pad on using the indicators. So I don't know if I've got one here. Let me just find one. If you've got a product, which one have I got? Oh, I've just got an extra here. All the pads, if you can see, if I can get them in the right place, they all have an indicator strip on. And there's a yellow line there, and then we have another one there. So if, not the best to show you, but if the pads and it's still yellow, then you can wear that product for longer, and you only really need to change it when it's 3/4 of the way blue. Okay, so that's a guideline that people don't often realize is what is on the products. And if you use one of the tenor slip products, it goes, I'll just grab that one, it goes all the way down this way. Can you just see that line? And that's giving you the indication when that pad needs changing. Okay. So again, it keeps all the way away from the skin and it doesn't resurface. So really, really good and helpful these days. So that's really the presentation we've got without going all into Leslie's. She was just saying about the wetness indicators. And again, if you store these away, they should be, like, say, in the patient's room, or you don't want to be them stored in a bathroom where there's moisture, because the pads will start to absorb moisture from their environment. So if you can try and keep them in a dry storage, they work better, and they'll be better for when you do get them out and give them a shake and put them on your residents. Just looking at that just reminds me about cream. If people do need, cream through getting, pressure damage, moisturizers, we would recommend Derma S, and with that it's just a little pea size just on the affected areas, so you don't need to go smoothing it all over, say the sacrum. You can just put it what's red and what is needing the cream at the time, and then once you've put it on, you don't need to keep reapplying it. I think it's about, I'm now having a little guess because I've just put myself on the spot, about every 48 to 72 hours. I don't know if you're agreeing with that, but that's what we would recommend for any, soreness on the sacrum. So we could move on to any questions and anything that you're finding in your daily, work environment that you feel that you want to ask Bladder and Bowel while you've got a chance to say your problems, and see if anybody else is experiencing the same issues. Anybody got any ideas?
Yeah, can I have a question?
Yeah, please go ahead, Joanne.
I understand why the pads are shaped as they are to fit the
Yeah.
body.
Yeah.
However, if somebody is consistently urinary incontinent, what do you feel about turning the pad the other way around?
Yeah, that, as we'd say, it's a big no-no. You haven't to do that. So even if I can't show you very well on this, but if I try and bring it a little bit, if you see, this is a large pad. Sorry, I just got this one. But if you see the shape of this, that is for the front of you, for like the pelvis. That is the area designed specially to go underneath. And then this larger area is for, your bottom at the back. And then that, even if it's just for urine, when people are sat, this is what again absorbs the right area, but you haven't to do them that way around, because as you can see, the shape of the pad would be totally wrong, because this middle bit, if the position, you get a pad, you put it like a banana, you go front to back, and you put that over like the pubic bone, and so this bit here is the absorbent part for the main urine that's being expelled, but then it's still got this area to go to, and this pad holds up to 850 mils and a little bit, and about a third more. So all the pads, I can go through them all, what they are. So like you've got your mini super, which is 400 mils absorbency. You've got the Tenor Comfort Normal, which is the peach one, which is the 450. You've got Tenor Comfort Plus, which is the blue one, which is 650. We've got the Tenor Comfort Plus, which is a 651. We've got it in a compact now, so that's just for urine. So if you want the 650 and its bowels included, sorry, you would use the original Tenor Comfort Plus, and the compacts for just urine. This is the 851, and then 900 is the Tenor Comfort Super, which mainly I would say is a nighttime product. Not always, but mainly, which is the green. So if they're worn with the fixation pants, which is the netty pants, hopefully we'll keep them as dry as we can. And again, you've got little frills on the legs, so make sure that the frills are always sticking out, because if they get tucked in, that's when people could end up saying they've got leakage and they've been wet. And sometimes it's just something as simple as putting those little elastic parts there. Make sure they're out when you're pulling them up onto the resident, and they should be as dry as possible anyway. So that's the comfort range.
Thanks,
Okay.
Kate. Does that answer that for you, Joanne?
Did that? So really, no,
Not
use them
really,
as they're
because
designed.
we all know, all of us know that 4 pads in 24 hours, nobody's using 4. They're always using more, all of them. Don't matter how well you're putting on a pad.
It's from our service. I suppose they've to make policy and guidelines, and unfortunately 4 is as much as the NHS will allow. So if people put on the prescription they want 5, and it will, sorry, but it doesn't change things. It's 4, and we would have to ask the person, they will need to purchase that extra product. Sometimes they do get carers allowance for this purpose, but that's not something that I'm really familiar with. But I always think if they get the majority of the pads taken care of by the NHS, it's sometimes not too bad, not too bad if you can just say get 1 packet for the month or 2 packets. And if you do go through Tenor again, and you're already on the prescription, you do get 10% off if you talk to Tenor direct. So if somebody does want them, they would give them a little discount, and they wouldn't charge them delivery if they had them delivered with their other products.
Okay.
Yeah, so sorry, but that's the best we can do with that. Really, it's just for.
Do you still do the slip liners?
No.
Because they
Over
used to
the
be an
years-
they used to be an additional, didn't it? It was an additional 400 mils that would help, because we had or we still have a lady that's very highly incontinent, and she was on, we had ID Expert, and she was on the highest range that we could have, and it was something that I asked for, and they were at the time, but then it just sort of stopped. So I just wondered if that was because it was good. It was an additional 400 mils that could be held.
Yeah, I'm really sorry. It's what it is now. So there's no liners, and like we don't give any bed, sheets or anything now. It's just the products mentioned on the prescription.
Yeah.
Yeah. So sorry about that. Again, we would advise never to double pad. Nothing to do with what you're saying now, but it just threw me into that. If you do go into any care homes and somebody's got 2 pads on, they're not actually achieving what they think they're achieving, because the back of the products are like of a plastic base. So by the time the urines come to that level, it's not going to go through the next product.
No, it's going to come out the sides.
But people feel that they're, doing themselves, what can you say, doing good to put 2 on, but that's just making them hot and not doing what they're actually trying to do. So if you can try and talk people out, if you notice they've got into that habit, and especially like we don't, like I say, as a service discuss the pull-ups, but people do put other products in pull-ups as well, which that comes back to us, that they think they're making the pull-ups last a bit longer because they put in another insert in the nick apart. So we would say don't double pad, or if you do see somebody, please explain to them not to do it.
Thanks, Kate.
Thank
and Katie's got her hand up.
Hi, Katie. Sorry about that.
No, you're all good. Thank you very much. So we do care rounding every 4 hours, roughly.
Yeah.
We're certainly with our residents who are in bed, dementia, etc. Now, to have our carers understand that actually it's down to assessing the pad. Is it full? Is it not? They sort of go, oh my God, we're a little bit wet, we're going to change the pad. Obviously that defeats the object of one, we get 4 pads per person per day. So can I just ask you, what's the longest amount of time someone should be in a pad for, the same pad?
Ooh. That's a bit of a strange one, because it depends how much is actually passing urine during that day. You would want it to be changed, obviously, within the 24 hours. You won't want it to be kept on longer than that. But because of the design of the pads and the fact it takes the urine to the bottom of the pad, while those lines, the blue indicators, they've been designed specially to give people, like carers, an idea to change them. But sometimes if they're on this 4-hourly rounding, I do understand that they do want to put them with a nice clean product on, and I think that's just human nature, isn't it? You clean somebody up, you take them to the bathroom, say, or just clean them because they may still be in bed. But from our point of view, we would just kind of say there's that blue indicator strip to watch. And you are, like you say, with the policies, you're not harming that resident or patient by leaving them in it. It's just how we feel as people. And at the end of the day, we're all people, and we're not just down to money and products. You've got to. So it's a strange one, really. But obviously, like you say, if they've soiled in that pad, then it's change it right away. But from our point of view, no matter what, we're only giving 4.
Yeah, I totally understand. I think you know, people who are experienced in using incontinence pads will generally know about the indicator and things, but I know
Yeah.
certainly newer staff were having to do a small teaching session just so that actually, but they know the indicator, etc. But
Yeah.
it's also, again, the human factor comes into it. But then as nurses, we go, well, actually, we're only getting 4 in a day, you know,
Yes.
if we don't need to change it, let's not.
Yeah.
But most people feel really uncomfortable with that.
I
So
would myself. Yeah,
yeah,
I would
I
myself.
totally agree. Do you have any, I'm sorry to ask
No.
this, everybody, do you have any like pamphlets on, so that the carers I can distribute in our home how to, you know, and I know it sounds really common sense, but it's not for everybody, about the indicator on the pads and things, just because I think it will go a long way with trying to,
Right.
shall I say, egg out, as long as they're safe and they're not got skin integrity problems. If that's something that's available from Tenor, that would be really helpful.
I will contact Tenor and see, because they've got all sorts, you know, and if somebody doesn't ask, then we don't think to get that information. So yes, that I will try and see what we've got that we can send out to you.
Thank you so much
That
for
would
your
be
help.
great. So if anybody else feels they want something like that, send in. Again, just pop your name on the chat box, and that would be great, because once this goes wrong, it's a big thing for the, not just the resident and the patient, but for the home and for the staff and for the washing of the clothes and the changing of the bed. You know, it's got such a big effect that we do want to get it as right as we can, you know, the first time. But then I do sometimes send samples out if I'm not very sure, you know, what I've got in front of me. So it gives people an opportunity to try different things. So if you do ever at any point, you know, if any assessments come in, think, oh, we could do perhaps with a sample because we're not just sure of the waist size, or you know, the hip or the absorbency even, because sometimes people just are not very sure, and in those 3 days you can get 3 very different days, which sometimes when they come to me I think, well, I'm not sure what this person really needs. So communication is important, and I can send samples out, because once that delivery's gone out and you've received it, you can't, unfortunately, it sounds a bit awful saying that, you can't tell me 2 days later this isn't suitable, because you've received it and you've accepted it. Okay, so we can rejig and get something for the next delivery, which can vary regarding how many weeks it is within your home. Like some homes are only every 12 weeks. Some of the bigger homes have a more frequent, you know, delivery, but in a way that person's had that allotted money spent on them. So if the order's completely wrong, so this is why we need that extra thought before it comes to me, please. You know, just like rethink, oh, is that going to be right? Or even with like the measurements of the waist, if you measure the waist and then measure the hips in centimeters, that again stops any you know, and I do get them that they're crazy wrong, you know, like sometimes people order extra small and they want it in extra large, do you know what I mean? And they weigh out. So if we have to send more out, again, it's just like a bit of human error, but even to get the Tenor fixation sent out, it's £10 delivery alone. So if you think of everything else that we do send out, this is why we need it to be as accurate as we can, because not only is it the products, it's the deliveries for Tenor that are costing the NHS all the money. So this is why we're coming out trying to explain to people how important it is to be as accurate, and don't just think, oh, that'll do, you know, reread it and re-look at it and look at your patient and resident and think, have I got this right before I send it off. You know, it's really important now, because I'm not saying they're not there, but we're very looking very carefully at what comes into us now. They will get everything, you know, they will get the products, but the more you give us as that information, the easier it is and the more correct product will be for that resident. So we do go up to 3XL in sizes, and in the slips, again, we go up to 3XL, and the absorbency is about 1,295. So if you get somebody having, say, about 3 or 4 of those, it's like the void can be like over 4,000. So that there's some big, products that can help, and you might think, oh, that would suit somebody that you're looking after at the moment, because they are high absorbency products, which sometimes you may not realize. I do have one of these, which you might all, it's a little bit curly, but a little bit. These are very good. You can't see it now. I'll let Anne look at this. I could perhaps get one of these put on my thing. Oh, you can just see a little bit of it there. And this is a product guide from Tenor. So if you want one of these, anyone, these are really useful. And when I did start this job at the beginning, and I've just been into the community nurses this morning and left them one, and they're very useful for knowing which product, and it's got all the absorbencies on. Oh, and I can't show you very well. But this is a Tenor product guide. So again, I can contact Tenor and get these sent out for you, and I'm sure you'd find them very useful when doing your assessments. They're really
Katie,
great.
yeah, thanks, Katie. I think that's really helpful. Questions and response, Kate.
Good.
Because what I was going to suggest is anything that can be sent digitally, we can send round with as a resource. We can send round, and if there's stuff like that which they have physical resources, if anybody who wants them could identify, well, I suppose if there's physical resources, if maybe they could send pictures of what they are, because then I could send those round with people's certificates and the presentation, and then they could identify if there was physical resources I'd like, if that would work for UKTON for everybody. And also Rachel has very kindly offered during the session in the chat that they have a great member of staff who's managed to make the poop diary look appealing, and she's very kindly offered to share that as a resource as well.
That's wonderful.
It's brilliant. So I say, Rachel, make sure your staff's name and the home or whatever
we always
are on
have
it.
Because she literally has made poop look pretty.
That's really good. I haven't seen one like that before. Well done.
And it works. It does work.
Yeah, it's very effective.
Because
So,
it makes you think
and
twice.
similarly, if anyone else has got any resources that they would recommend or they'd specifically like to ask Kate if she can access, that would be really helpful. Just let us know, and we can keep communicating, Kate, if that's all right.
Please,
to get those appropriate resources out.
Yes, that's the point of these days, isn't it?
That's amazing.
That'd be great.
And does anyone else have any questions for Kate?
I'd like to know, is there any up-to-date research regarding postmenopausal symptoms and bladder control? Because we don't seem to have moved on any further in the last 20 years on women's, in particular, on women's incontinence.
Right, I'm gonna bob that down, because I can always pop that to my superiors, can't I? Because we all do different jobs in bladder and bowel service. We're a bit lone in what we do. So whereas I'm mainly, Tenor products and the care homes, etc., they'll have other information that I'm not really in touch with, but I can find out for you, because it's not something I can just relate back to. But I don't think perhaps much has been done for
No, probably not.
menopausal. So apologies.
And it's really helpful to identify that, because one of the things that we're wanting to do with the forum and through DCHC is identify where there are challenges. Shared learning around challenges, and what we can do to support that. So it may be something which is a group we could push. If Kate, you come back and sort of say, well, no, there has been nothing. It maybe as a group we'd have a bigger voice to identify, actually, we need this to be looked at within the acute, and we need some support and guidance around that. So Kate, if you can ask that question and feed back,
I shall.
Then as a group, that would be great. And then as a group, if we feel there isn't enough response there, not from Kate, but if there isn't enough up-to-date response from the acute, then we can be using our voice to identify that this is something which is required. And it's very topical, obviously, isn't it, at the moment? Postmenopause is high on everybody's agenda,
Yes.
and the impact that it not having been on people's agendas for so many years have had. People are
Yes.
kind of trying to redress that. So very topical question. Thank you.
Yes, that's a good question. Thank you. Yes, we'll find out.
Thank you.
Yeah, thank you.
And Rachel said we'll be sent the PowerPoint. Kate, you're happy for that to be sent, are you? Sorry, I put you on the spot a bit with that earlier.
You did a bit. I'll be honest, we don't usually send it out because we put these on every 6 weeks as our team. And I'm just wondering if there's anything of Leslie's on here that I perhaps just need to look at. Because I don't want to step on somebody else's toes, if that's all right. But if it's all right to send it out, I'll just have another quick look, if that's okay, because I know she doesn't like it being sent out, Leslie. So it's because we put our sessions on every 6 weeks. I think we feel if there's a presentation out there that people won't attend.
Yeah.
I think
I was
that's how
just
she
going to say
sees
we could
it.
use it for our pop-up sessions. That's the only reason why.
Yeah. If again, you just let me just check with Leslie if
That's
you didn't
okay.
mind, because
No,
she could
that's
be
fine.
not very happy.
Absolutely. And one thing
But-
I didn't sort of make clear at the beginning, and apologies, Kate, I should have done,
Sorry.
is that Kate stood in with the presentation. The person who is going to give the main presentation, unfortunately couldn't last minute. So that's why Kate and I were having discussions even up to 10 minutes before
We did.
today. Lots of last minute. So Kate has very kindly stood in to offer this presentation. And maybe, Kate, if there's some elements which as a team you're happy we share, I could work, if you could identify which slides they are, I could put them on a separate slide to send out to people.
More than happy,
Identifying why you'd like people to attend the training, because obviously that makes sense.
Yes, but yeah, I'm not being difficult, but I'd rather just have a minute to rethink what's on here. Thank you.
Yeah, of course. Thank you.
Thank you. That'd be really good. Oh, I tell you what, just before I go, I've just thought again, I hadn't mentioned palliative patients. And palliative is obviously something that we're all dealing with. If somebody is, how we say, for like say the last month of their life, which again is like a syringe driver, a bit bedbound, not eating very much. If we just get a tenner prescription, we can add them and send them 6 packets out without all the 3-day diaries being completed, but we'd have to have written on that it's for a palliative patient, and then we'd send 6 packets out quickly without all the rest of the information needing completing. If it's palliative in the last year of life, we understand it's still palliative, but we'd need everything completing as per normal. But there is that, quick fix if you've got somebody that you've just, found that's palliative and you need some products for. So that's just to keep in mind. And
that's really helpful.
Anybody with a catheter as well, they can have products, but we usually, because then obviously it would be for bowels, we just usually give a tenner Comfort Normal for bowels.